one. This is CDC data on the relative prevalence of placental problems versus structural genetic problems. This whole 2 days is about genetics, and at best, 3% of pregnancies will suffer from genetic problems, with only 1% having a serious or severe genetic problem. So less than 1 in 100 you will live and have a genetic problem. The vast majority of babies that you will lose, that will die, or will be handicapped or neurodevelopmentally impaired, will occur as a consequence of placental problems, fetal growth restriction, stillbirth, and preeclampsia. And the vast, great paradox for me is that we're talking today about tests that cost $2,000, $3,000, $4,000 on a single woman. Yes, we use a $120,000 machine to scan someone for a structural problem. Yet the systems in place for us detecting, mitigating, and preventing fetal growth restriction and preeclampsia are prehistoric. They're from the last century, and they were, and still are, the same as our grandfather and grandmother obstetricians used to do. So I think we need to consider perhaps a modernization. And I'll tell you something now from the Royal College program in the UK, which has been in place now for 3 or 4 years and is gathering momentum. This is a particular study called Each Baby Counts. Each Baby Counts look at a few thousand babies, not just babies that we lost due to stillbirth, but babies that were severely handicapped or had HIE or cerebral palsy after birth, so-called severe or near-miss babies. And they found 2 consistent problems that contributed towards these near misses. And the 2 problems were inappropriate or poor risk assessment of the pregnancy. When they went back and they looked at the risk assessment of the woman, they found that many things were missed or inappropriately assessed. And that occurred in almost 3 out of 4 cases of these several thousand babies that either died or were handicapped or had cerebral palsy. The second thing they found is that you, the doctors out there, 2/3 of the time, despite making the correct diagnosis, you did not undertake the appropriate management that was in place according to either evidence or guidelines that were published. And they consider that a training issue, that you need to be trained all the time, because despite being told what the problem was, you did not do the right things to do it. And we're going to now review why these 2 problems may be persistent and pervading and prevalent in your care. First is risk assessment. All of you use the risk assessment system on the right, or a variation of that, which is the NICE, or the Royal College checklist-based approach for assessing risk in pregnancy. Does anyone here do anything other than that? You know, you're all chewing, you're using your fork, that's fine. So you're using a 60-year-old, unvalidated, untested checklist-based system, which says, yeah, ask those questions with right. And the problem with this system is that it stigmatizes about 1 in 5 to 1 in 4 women. You automatically call them high risk. And in a checklist-based system, when you tick a box, you assume that all of these things have equivalent risk. So a woman who's smoking has the same risk as someone who's using crack cocaine. Is that right? Yeah. And it's simply not right. All of these factors have different levels of risk, but in the checklist, you cannot distinguish between them. There are also arbitrary thresholds. For example, a woman who's 39 years old, 11 months and 30 days is low risk, and then she has a birthday tomorrow, and then she becomes high risk. Have you ever asked yourself, how does the baby know how old the mother is? How does the baby know what ethnicity the mother is? And especially in Singapore, how does the baby know what passport the mother has? As far as I can see, Singapore is of no specific ethnicity. You are the most beautiful smarty box of people of all colors, heights, credences, languages. And yet you have a Singapore national chart. So the baby must know what passport the mother has, right? Okay. And then you have this issue of ignoring the interaction of risks. So you may tell a mother she's high risk because she's 40, but you do not reduce her risk because she's healthy, She's had 2 babies in the last 5 years. They were both normal weight. She didn't have preeclampsia. She delivered spontaneously at 39 to 40 weeks. She doesn't smoke, and she's an ex-Singapore Olympic athlete. Is she really high risk? Or would you rather say that the 25-year-old girl who's a little bit overweight, who smokes 5 a day, is more high risk than the 40-year-old woman? What that means is that you're using this checklist to stigmatize these women for any of these things, but you're not using this checklist to reduce their risk for the absence of these factors. You're only using it in a positive discriminatory way. What that means is that you have a high false positive rate. 1 in 4 people are high risk, and it cannot be that 1 in 5 or 1 in women in Singapore are high risk. Then there is the issue that during COVID, we realized that ethnicity and socioeconomic deprivation are the strongest drivers of adverse health outcomes, not just in pregnancy, but throughout medicine. And nowhere in this checklist do we assess socioeconomic deprivation or ethnicity. It doesn't appear in the checklist at all. So the 2 strongest drivers of adverse health outcomes are missing from our risk assessment system. And if you don't believe me, the final thing is, the woman comes into your office, you do the checklist, you say she's high risk, right? And then she says, thank you, doctor, you're going to save my life. What is my risk? And what are you going to say to me? What is my risk? How can you possibly accept that you're risk assessing the pregnancy if there is no numerical risk? Yes? If you don't produce a numerical risk, we must stop fooling ourselves and fooling the women that you are indeed undertaking the risk assessment system. So when the Royal College finds out that 70 to 80% of the time, when things go wrong, we haven't assessed risk properly, actually it's probably 100% of the time. Because we don't assess risk properly. This is not a risk assessment system. What about doctors not undertaking the recommended evidence? Well, this is an issue because right now in the UK, there are actually 93 published NICE documents to do with maternity care alone. 92 documents, each of which has about 20 recommendations. This is not taken into consideration Department of Health recommendations, surgery recommendations, Royal College of Midwife recommendations, and hospital protocols and guidelines. So at any given moment in time, when you see a woman, you have to remember something like 3,000 to 4,000 different recommendations and deliver it in a context-specific manner for that woman. How likely is it that you do that? Well, I'm telling you now, 2 out of 3 times you won't, because that's what the evidence shows. And it's only because most women will have healthy babies that we get away with it. So most of the time, we are not following guidance or recommendations. We're certainly not following evidence, because I found out that the whole of Singapore does not contain a single computerized CTC machine. There is one somewhere in Malaysia, just on the other side of the border, apparently, but not in Singapore. And the evidence would suggest that that needs to be done. So, yeah, we're not even following the published evidence. It's no shame, because every day there are 10,000 papers published, academic papers published. You can't expect to read all 10,000 every day. I read them for you, and I'm going to present them. So, in view of these modernization that's desperately required, the Royal College set forward and decided to develop a digital tool to help us modernize and deliver better care. And this is called the Thomas Clinical Decision Support Tool. It's a piece of software that was developed during COVID and is now being rolled out. I will tell you about how it's being rolled out. And the targets for us were the things that occur commonly and we can prevent. We cannot prevent a structural problem. We cannot prevent a genetic disease. There's a doctor who came to me absolutely distraught that she might miss her cerebral dysplasia at 37 weeks. So what? We couldn't have prevented it. It's going to happen. It's too late to terminate in Singapore anyway. We have to live with it. I think probably we're more scared of being sued, but actually it was going to be there and it can't be picked up at 20 weeks. But these things can be prevented. And the system is that the software was there to help prevent the placental dysfunction problems and preterm birth. And this software was developed together with women, equal partnership with women. So the software we developed is shared between the women and us. So they know what we're seeing, but they see it in friendly language. And it contains a certain number of interventions. All women in early pregnancy will have these 2 things here, which there's the small word, no small word, okay. On the left-hand side, preterm birth assessment, the risk of preterm birth at 12 weeks, a placental function assessment, which is the FMF algorithm for preeclampsia before 16 weeks, and all women will have that. In later pregnancy, depending on whether they turn up with threatened preterm labor, they may have a preterm labor assessment or reduced fetal movements, and at the end of pregnancy, a time of birth assessment, later on Alzheimer's assessment at the end of pregnancy. So these are the 5 interventions in pregnancy, and the software can help deliver these risk assessments and deliver personalized care to the individual woman. If you weren't aware of it, this is the guidance from NICE, which was based on the study on the left. On the right is the Asprey FMF study in the New England Journal. On the left is the preliminary study, which in the UK was a head-to-head comparison between the checklist that you use every day versus the FMF algorithm. And this head-to-head comparison showed that the FMF algorithm halves the false positive rate. So you will tell half the number of women in your hospital that they're at high risk, whilst at the same time it doubles the prediction of adverse pregnancy outcomes. So using the FMF algorithm is 4 times better. Yes? Half the number of women being told they're high risk, whilst doubles your ability to predict the ones that are going to have adverse outcomes. So there is head-to-head evidence against the checklist to show you that it's better. And this is an NIHR conducted study in the UK in 7 hospitals over a year. On the right-hand side is the demonstration of evidence in an RCT from the Asprey trial to show that just for preterm preeclampsia, if you give them aspirin, you can reduce off, yes, significantly by 70 to 80% preterm preeclampsia, and much greater reduction in risk for term preeclampsia. So, good evidence. Yes, there is an alternative to the checklist. That alternative has been available for over a decade, 10 years, but we're still not using it. Well, the software tool that we developed, the woman puts in her own age, height, weight, history, etc. We just have to put in blood pressure, PAPE, and do a uterine doctor. But it doesn't matter if you do uterine doctor if you've got the biochemistry, but you can do personalized uterine doctor, which is super simple. And we put those factors in on the left-hand side. Have you got them yet? I've used the other one. This one is okay. No? Okay. Ambidextrous. So if you look at the left-hand side, a CRO is put in, we measure a blood pressure, you put in a PAPE, if you do uterine doctor, you do an doctor, you press a button. This is free software in the UK. It produces a risk. You can say it's high in case you don't know what the number is. It gives a big red spot and says it's high risk. And the woman then tells you offer aspirin and schedule scans. Okay? Just so that you don't lie to the woman or you don't forget. The woman gets a message at the same time saying, Dr. Laycock should now, all right, talk to you about aspirin and offer you some scans. Not only that, 2 weeks before the 26-week scan, he said, Dr. Laycock should have arranged a scan for you. Has he done that? If he hasn't, please ring him or his secretary and check. Got it? Okay, so it checks out and makes sure all the information is used. What we found out in the UK, this is a single center study, is that the implementation of the FMF algorithm with aspirin, but not just aspirin, but to have serial scans and early elective management results in a significant reduction of preterm preeclampsia. Also results in an increased detection of STIs at birth and a significant reduction of perinatal mortality in those groups. What was most important is because the FMF algorithm contains ethnicity. In the UK hospitals, there is a threefold difference in the perinatal death rate between non-white women and white women. And this was St. George's data before the implementation of the algorithm. In the 25,000 women since the implementation, there's been a significant reduction in perinatal death for women who are black, brown, or Asian. Okay? So this is the only hospital in the UK, but it certainly was a few years ago, that has that equity of care that we desperately look for. And the question is, why is it that when we do a pre-eclampsia risk assessment, that we have impact on detecting SGA and reduction in stillbirth? Well, the reason is preeclampsia is not a disease. Neither is being small a disease, and neither is dying a disease. Only in obstetrics do we have people trying to develop a screening test for death. We don't have it after you're born. We don't have adult death screening tests, but in preeclampsia there are at least 20 publications looking at the screening value, sensitivity and specificity for stillbirth. But these are all outcomes of placental dysfunction. You may be small because you don't get enough food. You may die because you don't get enough oxygen. You may develop preeclampsia because the mother's cardiovascular system decides to overpump, increase the pressure to perfuse the placenta to make it work better. And we now know that preterm birth is increased, spontaneous preterm birth is 2 to 3-fold higher in women who have placental dysfunction. You can argue that it may be a survival mechanism. The mother would rather kick the baby out than develop preeclampsia and die herself, perhaps. And you can see that in our first cohort and audit, we found that women who are high risk for preeclampsia also had an increased risk of preterm birth, also had an increased risk of SGA, such that our high-risk women, 45% of them had an adverse pregnancy outcome that you would not want to have, or you wouldn't want your sister or your daughter to have, or your wife to have. So when you are high risk for preeclampsia, it means you are predisposed to placental dysfunction, so you're actually high risk for all of these things. What about preterm birth risk assessment? You say, well, we do preterm birth risk assessment, and now you realize you use a checklist or a very spurious or sporadic way of assessing preterm birth. What was obvious, yes, is that there's huge variation in how preterm birth risk is assessed in hospitals in the UK, and I'm pretty sure it's the same in Singapore. And when we looked at preterm births, severe preterm births, we found that there was a massive disparity in how things were provided. Asian women were less likely to be referred to a preterm birth specialist, despite having the same history as white women. Okay? And there is an inherent bias in how we refer people by who asks the questions and what questions are asked. And therefore, we introduced a screening algorithm and an externally validated, known functional screening algorithm. The screening algorithm is not there to predict preterm birth with accuracy. The screening algorithm is there to give us a risk assessment so that the right woman can be equitably sent to see a preterm birth specialist. And that algorithm, if you're high chance, you go to the preterm birth, which is about 5% of the women. If you're moderate chance, which is another 5% of women, they will have a cervical length assessment 18 to 21 weeks, because this is not routine in the UK. And the low chance women will have standard care during the pregnancy. And these are the two main risk assessments that women will have. If they turn up later on in pregnancy with preterm labor, Laycock, you just admit them, give them steroids here. Is that right? All of them? No, you send them all home. You keep them in or you send them home? Or they sleep in the car park like most of the doctors here. You assess. And she's in preterm labor. You're going to keep her in, right? Give her steroids. Yeah, you are. Okay. Oh, it's no different for the UK, but the recommendation in the UK now is that you must do a QIP or a EQIP, an algorithm to look at their possibility of risk. And this is available online. But the problem is, it's good, but the problem is it's not used consistently. It requires the doctor to go online and do it. There's no record of the data. So if they enter the data wrong online and they press the button and they send a woman home, the woman will say, well, how do I know the doctor did the assessment correctly? Yes. Because it requires duplication of data. There's no report of the result either, other than what the doctor wrote, and there's no decision support. It doesn't tell them what to do. This is an online tool. It works very well. So what we did was we embedded it in the device such that the doctor doesn't have to do any of those things. All they have to do is put in a cervical length or a fibronectin level. So it reduces unnecessary hospital admission because you can send 90% of your women home who turn up in preterm labor. 90% of them will avoid steroids, and you can avoid the discussion of whether I should give them 1 or 2 or 3 courses because you don't give them a course at all. It reduces NICU bed blocking. It may not be a problem in here, but in the UK we don't have enough neonatal beds, and therefore sending a woman home means that cot is not working. It's an extremely simple tool. All you have to do is put in either cervical length or fibronectin. You don't have to do anything else because the device remembers all of the maternal history. Alright? So literally within seconds of you seeing her, you can decide she's suitable for observation and discharge home, or it will say admit and transfer to a tertiary level care which can provide the neonatal care. And the woman gets it as well, okay? So you can't hide. She gets told what your doctor should be doing. So there is engagement of the woman in her care. It may not be popular in Singapore, and it certainly isn't popular in the UK, but I don't think you can argue that it shouldn't be done, right? Okay. What about change in fetal movements? What do you do here when someone comes? Tony, what do you do when someone, not in your golden palace, but you know, in an average hospital? Reduce fetal movements, you just CTG and Simpson's fundal height, and then it's all okay, you send it home. CTG, okay, good, all right. So I love the fact that we have protocolized care. In the UK, protocolized care, the NHS is really good. We deliver good protocolized care. Yes, the woman comes in, we always do the CTG. The issue is, it considers the 650,000 women living in the UK as exactly the same. Is that the case? Are all women the same? Then why are we doing the same thing for all women? It's not right. Yes? Especially in this day and age where we have this personalization. Tony, you can travel in business, I travel in coach. This is personalization, right? Okay. Okay. So what this does is it takes into consideration many, many things. It takes into consideration her a priori first trimester risk, her gestational age, whether she has presented before with reduced fetal movements, and based on the combination of those features, and whether she's at term, whether she's at 39 weeks, it'll put her into, for example, auscultation if she's 24 weeks or 26 weeks. You say just, a low risk woman, just say, listen, don't even do a CTG. Just tell her the baby's alive and send her home. It may do a computerized CTG, and remember there's a little C there. The little C is really important because this is an evidence-based tool. You cannot recommend things that are not evidence-based. Or, for example, if she's had 2 episodes, yes, and she's 34 weeks, it'll say, actually, you must perform a scan if one hasn't been done in the last 2 weeks. And if she's at term, she's 39 weeks, and presenting, she's either high risk or it's a second episode, it'll say, consider induction later. You have to understand that there's a degree of personalization here based on the risk. It can save you a lot of work here, and it can save you missing a stillbirth delay. It certainly will tell you what the right thing to do is. And the reason we did this is that despite having this personalization written in the guidance, we found that the majority of doctors seeing women with reduced movements were just following a protocol of we do a CTG. They were not looking at the notes and saying, was she high risk? They were not looking at the notes and saying, did she come before? This tool will remember that she's been there before because on the previous occasion you pressed a button. The tool will say, this is a repeated fetal movement reduction. Okay, so it remembers all of those things, and this tool helps you. Finally, we come to the issue of timing of birth assessment. I gather there's been a lot of debate, and there are people here who believe that 39 weeks induction is the right thing to do. I'm glad to see that the patriarchy is still alive here in Singapore and still certain countries in Europe. Usually driven by older white men, right, who believe that women should do what they're told, but they can always decline. Okay? How sad is it that when you're booking your flights, when you're looking at your bank, when you're trying to catch a grab, you're using the most powerful technology in the world. When it comes to your profession, your responsibility, something you're paid for, you're happy to use a piece of paper. Yes? How impressed is a woman going to be when she has got a phone and she uses technology to go shopping and flying and banking and ordering a pizza? And she comes in and the best that the doctor has is either a physical piece of paper or a digital piece of paper. Is she going to be impressed? Has she got confidence in you? And certainly when she has that stillbirth or she has that diagnosis, of course she's going to doubt your skills and your ability. Because she's not confident that you're using the best that there is out there to look after her care. And this tool, because she sees it, she's engaging with it. She knows that you're doing evidence-based care. That level of confidence, yes, the fact that you're using digitization, the fact that you're personalizing your care for her is incredibly important. Please don't underestimate the value of this tool. So, there is a degree of personalization. This is as crude as it comes right now, but you need to understand that this is what we have at the moment. If a woman has, for example, a baby that's below the 3rd centile, she'll be offered birth from 37 weeks. If the baby is below the 10th centile, she'll be offered birth from 39 weeks. If, for example, she has abnormal Doppler indices, so if her CPR is low because the umbilical is high or the inside is normal, we don't yet know what the thresholds are. All right? So secondary studies from the ratio 37 will tell us how to interpret it, but we don't know. So at the moment, it says refer for senior review, and you need to decide what to do. If, for example, she has a high-risk placental function test from the 1st trimester, 25 to 30% of them will already have delivered for complications that you've identified, but 70% will be here. They are delivered at 40 weeks. So we no longer deliver for it being 41 years old, because the baby doesn't know how old she is. We no longer deliver for IVF. Yes, we no longer deliver for obesity. We don't stigmatize women for their physical characteristics. What we do is we say we're going to offer induction from 39, 40 weeks because you are high risk of placental dysfunction. You may be young, you may be slim, but your papa is low, your BP is high, and therefore we need to offer induction. So we've reduced inductions for unnecessary stigmatization and increased it for that. And finally, if everything is golden, you get over it. So this is a degree of personalization at term based on their inherent a priori risk, not a blanket policy that treats all women the same. They can, of course, you can do more. This is not a ceiling. This is not a prescriptive ceiling of care. It doesn't tell you that you cannot do any more. It says this is the minimum you should offer the woman. If you want to do more, you're welcome to do so, but you mustn't do less. Now, at the moment, what we did was developed and tested it during COVID. It's now working in 4 hospitals in the UK constantly. And just this month, the NHS trial, which is in 26 hospitals in the UK, has just started a randomized control step trial in the UK. And we now have a Gates Foundation trial in 3 countries, in another 50-odd hospitals starting next month, which is a trial of the no uterine Doppler, no biochemistry, but simply the algorithm in affording care in this. So we have at the moment 2 trials in over 80 hospitals in 5 countries undertaken in the future. If you're interested in this, there are 2 QR codes. One is a very simple one to go over the issue of why we need personalization and digitization. I've saved this one. This is the best one. This is kind of details of the Tommy's app, but you can't have the Tommy's app not unless your whole healthcare system is actually adopted. So I have a QR code at the top of the page. Now, in the last 5 minutes, and I didn't declare my conflict, but it says it on the program, this lecture is sponsored by Biorhythm. He's over there, Amrish is over there, a little stall, go and visit it, and I'm going to tell you a little bit about it. I was here for a meeting with them for the last 3 days. It is Singapore technology, and it is going to transform the way the world delivers antenatal care, so I think you should be proud of it. This is what you do. This is what Tony says you should do. You should do CTGs, okay? If you don't know, there is a problem with this, which is antenatally. There is an issue. Geography and capacity. You need the room, yes. You need the place for the monitors for the CTGs. I went to a hospital on Thursday morning. They said, we don't do CTGs. I said, no, you must do reason. They said, yeah, we do CTGs. I said, well, where do you do them? I said, we sometimes do a late board, sometimes we said, okay. Why? Because there's no space to do CTGs. You need a resource, you need a midwife, you put it on, or a doctor put it on, and keep it on and chase the baby around the abdomen. Right? And finally, we have this most important problem, which is the resource of the doctor and the variability of interpretation. There is Cochrane review evidence, there is randomized control trial evidence to show that the use of non-computerized visual analysis, doctor-based interpretation, doubles perinatal mortality. Doubles perinatal mortality. So the use of CTGs in Singapore at the moment actually worsens outcome. You would be better off not doing CTGs in your population and just treating them ad hoc according to their risk. However, the randomized control trial evidence suggests that the use of computerized CTGs certainly can significantly lower perinatal morbidity. So there is evidence to show that if we use the computerized version which produces reproducibility, repeatability, and accuracy, then that is a positive way to go. This technology developed here and coming out of Singapore is called FEMON. It uses ECG signals. It doesn't use auditory signals. So it's listening to the ECG. It takes the maternal ECG, subtracts the maternal ECG, and underneath there is the fetal ECG. And therefore it's very, very accurate. It can measure individual care. It has a high capacity. It's ambulatory. So you do not put this on. The mother takes it home, and she can put it on while she's watching TV, playing Game Boy, whatever it's doing. And it's a non-specialist application, consistent interpretation. It has computerization in it, so it will be able to, yes, tell you and her that everything is okay, which is the case majority of the time. We've done some phase 1 studies. We're finishing a phase 2 study now. And in computerized CTG, because I suddenly realized that most of you are not familiar with it, there is one particular index called short-term variability. Short-term variability is as it is in labor. Yes, it's the little wiggliness of the line, not the deep dips. And that short-term variability has been shown to be the gold standard. It is the best assessment of fetal myocardial health and oxygenation. A good myocardium and CTG and ECG, a measuring man, will have a good short-term variability. Yes, and the problem with auditory CTGs is that it can only tell you about short-term variability. It can tell you what it hears. When you use an ECG, you can actually measure the cardiac time intervals. That's like doing an ECG in an adult. What you may not realize is that the cardiac time intervals are actually far better at telling us about myocardial health than a CTG, just listening to the fetal heart rate. So actually this technology has the ability to actually take us forward and improve our prediction and ability of fetal myocardial health, which is what we do. It's relatively easy. Yeah, the mother puts it on, she's got a little application on her phone which guides us to putting it on, so you won't let her put it on badly, and then it guides us through the session, and then in the session you can upload the data. Yeah, it's now going onto a live cloud, so even you as the physician can access this CTG remotely from your clinic or from your own phone if that's what you want. Very importantly, it'll rank rate this, so it'll say green or red, and if it's red, you'll get an email and it'll pop up to the top of your workplace. So right at the top will be the 1, 2, or 3 women. Yeah, so if you've got Tony's practice, the 20 women or red lights. So you know that they're the ones you have to, the other people will come as well. So there's a system within it built in to keep it safe and reduce your liability. In case you want to know, is it very similar to all these signals? Absolutely. There is a very high degree of correlation between STV and ESTV. STV is the auditory one, ESTV is the electronic or ECG. STV, very high correlation, is about 0.93. And then when you look at the correlations with other cardiac time intervals, they're very strong correlations. But this is the most interesting and the one we found most fascinating. There's something called PRSA. PRSA is a cardiac time interval in adult ECGs, which is the best index of cardiovascular health. And what we found is a strong correlation between STV and ADCD. The reason we're interested in this is that PRSA actually is likely to be the future index that we use in the fetus as well. It's what we use in the adult. We now can measure PRSA in the fetus, and perhaps that's what we're going to be doing. Okay. So I'd like to end with this. AMBER 3, we're doing AMBER 2, which is phase 2 study. AMBER 3 will be a head-to-head study of remote fetal ECG versus hospital computerized CTG, just to show that this is non-inferior. And if you can show that, then there is absolutely every reason that female device will be the device that's used throughout the world to monitor women and the benefits are great. As long as it's not inferior to hospital computerized CTGs, it's cheaper for you, easier for you, more economic for you, it can be done more often. The women are happier, they're at home in their own environment with their children, in their family, in their own bed, in their own armchair. And it is likely that not only will it be non-inferior, but the heart rate indices, heart rate variable indices that we can measure in this chemo is going to be far better than what we currently have in computerized CTGs. So I beg you, we need to change. If we don't, we're still going to have the same preeclampsia of mid-coitus. We can still go directly to the class. Thank you very much indeed.
Thanks, Lasky, for a very interesting talk. And there is one question on the app and the concerns, but I think you did mention it. The Tommy's app is only for users with the NHS email addresses now. So any plans for open access? Because I think some of the people
It's an app for healthcare systems, not for individuals. Okay, so you need the entire system to adopt it. So for example, the NHS is not going to have this. It's going to have